You're listening to It Takes a Village podcast with Liberty,
Megan,
and Brianna, where you don't have to be perfect, you just have to be you.
Hello, everybody. Welcome to It Takes a Village podcast. Happy to be back.
Yay.
I was sick last time. I'm back. Don't forget to follow us on social media on Instagram. It's ITA_village_pod. So ITA_village_pod. Follow us on Instagram if you're not already. All right. So today we have a very special guest, Jessica Eckhardt. Welcome, Jessica.
Thank you.
We're so glad to have you.
Yeah, thanks for inviting me. Well, we wanted to start with a quick introduction. And I did want to say Jess and I know each other because our kids went to school together for a long time.
Yeah.
Wonderland and Lake
since
School.
They've been really little.
Yeah. So
We actually found out when Jess was here with me earlier that I know her son because of Avery. Because
Oh, yes.
Avery, son,
Yeah.
right?
Yep.
Yes. Because of Avery, because she's talked about Soren so much. And I was like, oh, sure, of course I know your
yeah,
family.
they're very good. They're very good buddies. But yeah. How about you start with introducing yourself and telling us a little bit about what you do?
Yeah, so I'm Jessica Eckhardt. I am the director of Western's Masters of Behavioral Science program here in Gunnison, and I'm a sociologist by training. So a lot of my academic career, my life has been really focused on understanding the way that systems work, especially as it relates to healthcare systems and medical behavior, and really kind of unpacking who in society gets sick and why. And then another part of my research is looking at environmental sociology. And so I bridge the two and I look at how environmental hazards affect human health and how those human health outcomes are exacerbated by social inequality, like poverty, racism, sexism, and so on. So
That's amazing. That honestly, like, such important work right now.
Yeah.
I'm just going to fangirl for a second because so much is focused on the individual right now in rhetoric and like how we're talking about things and how to solve problems. And while some aspects of that are individual, I think it is such an important thing to talk about the systems and this in sociology in general and how all of that. So I'm just so excited to hear more.
good. I'm glad to share. Yeah, and I love it too. It helps us make sense of our own lives, right? Like the way society impacts our individual behaviors, especially health behaviors. So I think there's a lot of power in making sense of our own experiences with this systems lens. But yeah, I think it's also really timely because if we're going to address any real inequalities, especially in health, we need to understand why those inequalities exist in the first place. So.
And today we're going to focus on talking about maternal infant care in rural communities, and then also the effect of climate change on reproductive decisions. So it's going to be very interesting. Before we get started, though, I was curious, how did you become interested in these themes and research subjects?
I've always been interested in, again, that systems learning perspective, especially as it relates to sexism and racism and poverty. And then as I got later into graduate school, I got really interested in health, and not really from a personal experience, but it's just fascinating to think that we live in a country that has some of the best doctors in the world, some of the best medical technology. We spend the most per capita on healthcare, yet we have some of the poorest health outcomes compared to other well-developed countries. And I just find that paradox fascinating and wanted to know more about it.
So from your perspective, how is maternal and infant care changing in rural communities today?
So there's a lot going on, I would say, within the last 10 years with rural health in general, but it's specifically at a disadvantage is maternal health and infant health care. So in rural communities, and I would like to add that rural communities across the country are very diverse. So we often sometimes stereotype rural communities into this very kind of binary box of this is what it means to be rural in the United States. But rural areas are extremely diverse. And so for us in the Gunnison Valley and in the Western Slope, we're really resort communities. And so we have unique characteristics. We have economic inequality because you have a lot of wealthy people that come to these beautiful places and have second homes or settle here. You have a lot of hospitality workers that prop up the resorts. And so you have this bifurcation or this economic inequality that really characterizes the town. So that's one element that's unique to our community. But in general, what we're seeing happen with rural health is that hospitals are closing. medical providers are leaving, and that creates a medical provider shortage. You also have a lot of rural areas depopulating, and so there's just fewer people in rural areas. And because of that, those rural areas can't support a hospital system like they once did. And so you have a lot of elements going on. You have increased poverty. You have increased diversity with immigration coming into rural areas and propping up some of the industries that rural areas survive off of, such as agriculture and hospitality. So we're getting poorer. Rural areas are generally getting poorer. They're becoming more diverse, and they're losing a lot of their healthcare systems and services. And so from maternal health, what we know, which is really fascinating, is that over the last 10 years, a third of rural hospitals, their maternal wards have closed. And it's partly because in maternal care, hospitals aren't getting reimbursed as much as birthing costs. And so it's a very expensive unit to keep open and run for a hospital. You also have medical provider shortages. So you have a lot of rural areas that don't have an OBGYN, or they have very few OBGYNs or midwives or other clinicians. And then you just have fewer people having kids. And so you see low traffic in these. And so all of those elements coalesce into hospitals having to make this really tough decision of closing their maternal wards. And we're seeing that all across the nation. And COVID made that worse as well. So,
Of course.
yeah,
And
it's tough.
So oftentimes, are they choosing the maternal wards over other areas of the hospital simply because of the cost? Like
Sometimes.
it's just the
Yeah.
cost.
Yeah. If at the end of the day,
It's a
if you can't
business.
make the books balance, and it's a business, or even if it's a nonprofit hospital, like Gunnison Valley Health, it's a tough decision. Nobody wants to make that decision to close these services that are really needed. So their hands are oftentimes forced into making those tough decisions. And what the consequences of that are is that women, they'll either forgo prenatal and postnatal care because they have to drive really far away. And when the time comes to deliver the baby, oftentimes they have to go farther away as well. And so when you think about it, it's fascinating because if somebody's having a heart attack, you wouldn't expect that person has to drive 2 or 3 hours to get care. Yet we're expecting women to do this for a natural, but also a very major medical event in their life. And it's worrisome.
Absolutely. I mean, it's just, like I think about, I drive to an appointment here. People are going to get angry at me because it's such a small town. It takes 5 minutes to get to most places, and imagining planning an hour and a half, that means taking time off of work. That means potentially if I had a specific type of job, that would impact my income. These are not just I can't get to the hospital. It's really life-changing to not have something close.
Definitely, especially if you have. So the other element of rural healthcare, especially maternal care, is that we see because of some of these services not being provided or accessible, women who live in rural areas, they have poor outcomes as it relates to things such as getting their medical needs addressed if they have things like gestational diabetes, sepsis, preeclampsia, which are really serious, possibly deadly illnesses that you would want addressed if possible. So rural women have a higher rate of experiencing those. And then for infants, the infant outcomes are also usually poor in rural areas as well. There's usually kind of lower birth rate in rural areas. And so it's a coalescing factor or cascading series of events that at the individual level, women are making these choices because they don't have access to care, and it's impacting their health. It's impacting their jobs, their checkbook or their bank accounts. So, it's not a pretty picture for rural America and women's health.
And then I would imagine that's also affecting available childcare in the rural community because there are less kids. Mm-hmm. So nobody sees that as a need to provide childcare.
Yeah. Or just the childcare system is broken as well, right? So you have these multiple systems. You have the healthcare system, the way that healthcare is funded. There's a higher number of women in rural areas that depend on Medicaid. And again, the reimbursements for Medicaid are usually lower than if a woman has private insurance. And so the hospitals closing or cuts to Medicaid and Medicare, for example, really disproportionately impact rural women versus urban women. So,
Right. Because a higher percentage of us are using Medicaid or Medicare to pay for Medicaid, right? I always get them switched.
Medicaid,
Yeah, to pay for certain things, and that is less lucrative to the hospitals, therefore causing more closures in rural communities.
Yep.
Okay.
Does that also impact the quality of care that they have access to? Like, are they treated differently because it is Medicaid, because the hospitals aren't getting reimbursed?
Yeah, there doesn't seem in the research to seem that doctor-patient interactions are different with people who are on Medicaid versus those that aren't. What it can change is the number of private providers that will take Medicaid. So, for example, in Gunnison, we don't have a single dentist that takes Medicaid. So if you're on Medicaid in the Gunnison Valley and you need dental work, you have to go somewhere else. Montrose, Salida, you have to find a dentist that takes Medicaid. So private providers can choose not to take Medicaid or Medicare. And often they do that not because they're malicious, but it's because there's a lot of paperwork, reimbursement rates are lower. So on the provider side, I've heard anecdotally that their hands are kind of tied and it just doesn't make sense for them to take Medicaid or Medicare patients if they have a private practice. So with hospitals, they're just getting reimbursed less, and at the end of the day, it affects their financial solvency. Mm-hmm. So
Yeah.
So prenatal care has improved in some ways, but what do you see are some of the gaps?
Yeah, prenatal care, we've come a long ways in the last 40 years with prenatal care. I would argue that that women are more aware of the importance of prenatal care, getting screenings, tests for pregnancy risks, also taking prenatal vitamins, following certain dietary restrictions, right? We all know that you're not supposed to eat soft cheeses or drink alcohol, smoking. So we have come a long way with, I'd say, like health education and health promotion as it relates to prenatal care. One of the biggest gaps I see is access to it. So in a rural area, you might just have less access to some of those screenings. Wait times for seeing your provider might be longer. And if you're pregnant, you're on a finite clock,
Yes.
right? Like, okay, I can't get in to see my provider for 6 months. Yes. You're already into the third trimester if you just found out you're pregnant. So there's access issues in rural areas to providing prenatal care and health. So that's really, that's really the biggest gap right now.
In Gunnison, is there, like, do you know specifically, do we have, I mean, there's access issues in general in rural communities, but like, what's our situation like in Gunnison? Do we have enough OBGYNs to go around?
We only have one OBGYN, but Gunnison, interestingly enough, we are not in what in federal terminology is called a healthcare provider shortage, because we have a lot of primary care physicians. Okay. So we don't actually have a shortage of primary health physicians in Gunnison. And oftentimes that's who you see for prenatal health. And oftentimes in rural areas, that's actually who's delivering your baby. But surrounding areas, definitely. If we're talking about Lake City, if we're talking about people that live all the way up in Marble, which is Gunnison County. So there are a lot of surrounding counties on the Western Slope that do have these critical provider shortages as it relates to OBGYNs and family physicians. We just happen to have a lot of family physicians here, which is lucky for us.
If you're, let's say, like, I'm a mom and I just moved, or I'm like going to become a mother and I just moved to Marble. Like, what do I do? How do I even how do you,
I think telehealth is one way that some women are getting prenatal health, but it's tricky if you need to have your blood drawn, which a lot of pregnant women do get their blood drawn, again, for testing of things like gestational diabetes. There isn't yet a really great model for that for people who live way out in our county. So you have to make concessions, and you either just skip that care or you take time off work and you drive the hour to the valley, to Gunnison. So it's hard decisions that need to be made that aren't always feasible if you are really isolated.
Do you see a lot of alternative options pop up in these rural communities, like doulas.
Yeah, I think it's becoming more common for that to happen. In rural areas, there's a lot of grassroots movements around maternal, infant, and postnatal care. I think doulas are a part of that puzzle. I think midwives are a part of that puzzle. There's also birthing centers. So that's not a hospital, but it is a medical facility where women can go under the care of a midwife and have a child. And state policy governs what birthing centers can look like in each state. But that's kind of a happy medium, right? You're not asking women to have birth in their homes. I also think, though, that there is growing acknowledgement that you can have births in the house under the care of a midwife and it be really safe and have really positive health outcomes. So, yes, I think that's part of the solution is expanding what we think childbirth and prenatal care looks like. It's not just this one model of it has to be in the hospital.
Is there something here akin to that, a birth center?
Not yet. I believe there's one midwife in Salida. I don't know if they're still practicing.
Oh, wow.
To my knowledge, we don't have a midwife in our valley. But if anybody's interested in listening out there and wants to become a midwife,
I feel like someone
that would
just
be
asked
great.
this on the marketplace. Someone was looking for a midwife.
Yeah, there's quite a few doulas, which is great.
Can we
wanna
state
have
the
you
difference for our listeners? Just
Oh, yeah.
So a doula is similar to a birth attendant. It's somebody that is there for the parents and an advocate for the parents and someone that's able to help parents make decisions in the moment, but they're not a clinical medical provider. A midwife is a trained and certified clinical medical provider. They can deliver the baby. They can do certain interventions depending on how your birth is going. They're also allowed to do health screenings, shots, vaccinations, and things of that. So they're a medical provider. You also have nurse midwives as well, and so that's kind of another advanced level of care. So doulas are great. Again, they kind of empower the parenting decisions during the birth process and are there for the parents, especially the mother. And yeah, midwives. So we don't have a midwife in the valley.
Wow.
Yeah. But I think that they would be busy.
I think I would be extremely busy.
Yeah.
But no, we don't have a birth center. And I actually just anecdotally, I had my first kid at a birth center with a midwife in Wisconsin. And that was a wonderful experience, high level of care. And then when I moved to Gunnison, I had my second kid in the hospital. And again, GVH was great, had a good experience, but they were very different in the approach to childbirth and the approach to aftercare for the mother. So it was interesting getting those two different models of care in my own experience. And so I think midwifery is an option for women if one is available.
So historically, women's health has been dismissed or misunderstood. How have misconceptions like female hysteria shaped the medical system and even research priorities?
Majorly.
Yeah.
So the first thing to understand is that because women were excluded from higher places of learning for decades, most medical research was conducted by men with a very male perspective. And that has really, I think, hindered women's health and our understanding of the woman's body. Women's health and women's bodies weren't prioritized in terms of medical research. It also meant that the male body was the default. So in most medical research, they're looking at the male body. And we see this with the way even things like harm reduction or safety features are created. Seatbelts, the default body for mannequin test dummies is like a male body. And so we find that women have higher rates of injury in car accidents.
Boobs get messed up.
Yeah.
Especially historically. Nowadays, newer cars, if you've ever noticed, you can adjust the seatbelt.
You
Yeah,
can.
You can, in newer cars. And that's because women were having higher rates of injury because seatbelts were tested for men's bodies. So things like seatbelts, Megan and I chatted about this, but CPR mannequin dummies, when people go to learn CPR, they don't have breasts. And so that can just cause this moment of hesitation, right? When you're working on a woman and it's like,
just all these really important chest things.
Yeah, exactly. So we see this. Those are maybe lower risk examples, but they're important because they highlight this bigger phenomena happening that women's bodies haven't been centered in medical research traditionally. And because of that, we don't know a lot about female issues. If we're thinking about things like endometriosis, we don't have a good grasp on that. We're not training medical providers to really fully understand the causes of endometriosis and treatments. Menopause is another one. What is menopause? What is happening, right? Our understanding of these issues is getting better and deeper, but it's really women leading the charge on the understanding. Yeah. So we have a long way to go to catch up with understanding women's health issues and prioritizing it, right? Funding it, making sure that it's given its due so that half of the population can have some answers to some of the things that they're living with.
Mm-hmm. Is there any way that the public can, this is probably not how this works, but like research funding, when people find out about how little is like funneled to different, like, can you speak to like how any of that decision making happens and like if the community can do anything about that?
Yeah, I mean, a lot of medical research is funded through the federal government. So through big organizations like the National Institute of Health, the Center for Disease Control. And I would say, if you're interested in a specific issue, you can always write your representatives and have them, make them aware of what's going on. Oftentimes you'll have representatives try to pass specific policy or legislation about research funding towards a certain area. So you can have your voice be heard that way. But yeah, those decisions are usually happening at a really big macro scale because we're talking about millions to billions of dollars to study these things. And there's a really robust system in place for medical research, especially for drug trials. So it's a lot of money and a lot of time to fully understand. Unfortunately, a lot of the health funding has been cut in the last 6 months with the new administration. And that's worrisome to scientists because it's going to set us back in understanding. And it's not just maternal health, but it's things like cancer.
Yeah.
Cancer research took a big hit with the cuts recently. So it's challenging.
Yeah.
There's also a tendency of not believing women's pains.
Oh, yes, 100%. So. Yeah, when thinking about that history of who used to be providers, who was allowed to be a medical provider, again, it was largely men. And there is a well-documented history of not believing women's pain and believing that women are making up their pain, that the pain is in their head. And those unconscious biases and stereotypes still can sometimes seep into current providers. And that's problematic as well. Yeah. I think now dialogue is being had about believing women's pain more. And so that it's not being ignored, but I'm sure most women in their life have some sort of story of going to a medical provider and maybe not feeling that they were fully heard or fully that their concern wasn't treated in the manner that they wished it would be treated as a woman.
It took me 4 years to find someone to believe I was in pain and I had endometriosis. And
Super painful.
The amount of times I was told periods hurt, it was like you leave feeling humiliated, like you're just not handling what it is to have a woman body well.
Yeah. It's the kind of the blame the victim attitude. It's like, okay, that's in, you need to have better coping mechanisms or you're
Toughen
weak
up.
Because
Toughen out.
you are not able to experience this pain that is quote unquote normal. But with something like endometriosis, it's not normal. And so that is such a common story, especially with women who have endometriosis or POS. Yeah, POS. And it's frustrating, it's demoralizing, and it can take years to get a diagnosis, and that's just not right.
Because then you
that
have
wouldn't
to
be
have the
acceptable
courage.
with other issues.
Yeah, and you have to have the courage to keep trying for yourself.
Yes. Yeah, it's on you to be your own advocate, and that's not really how our That's not how medicine should be run, and it's an additional barrier for women.
If you're in pain, how are you going to be like, Mom, I'm going to wake up today and advocate for myself? Like, that takes moving your body, that takes thinking,
And
which
after the
sometimes
fourth
gets so impaired.
doctor has told you that you're the problem, like, how do you call a new
internalize
doctor?
Yeah.
How do you find the energy to try again?
And I think there is this prevalent rhetoric that women's life is just suffering, right? Like, okay, you just have to suffer through your periods. You have to suffer through
sacrifice.
puberty. You have to suffer through menopause, which sometimes could be a decade long. And that's just unacceptable. And I think women are starting to raise the alarm on that. Like, we don't have to suffer through this. So
Yeah. One thing I've noticed is that women will often say, like, I prefer going to see a woman or a female doctor or, like, even anything. I feel that way. And I, like, just want to emphasize, like, this is usually why, because we are starting at a different point of understanding. We want to be heard.
yeah, and representation is really important. It's the same if we think beyond gender. It's really important to have doctors of color, Black and brown doctors.
Yeah.
That's really clear as well in the research, that especially with mental health providers, that you want to go to somebody that has similar experiences to you, and that's okay. That is valid. So the diversifying of the healthcare field is really important, because people might not go to you if.
So when we, just to go back, when we were talking and had coffee before we scheduled this interview, you had mentioned that some women providers also fall within that trap a little bit of not believing women's pain. So do you feel like that's something that's at a training level for our medical professionals, that's just not being talked about? It's like women's care and women's pains and the differences.
Yeah, I think that's part of it, is that at that training level, more attention could be paid to understanding women's issues, and also just the history of ignoring women's issues. I also think a big part of it, though, is that we live in a unequal society as it relates to many things, but specifically gender. So within our patriarchal society that is male-centered and male-focused, women start to internalize these messages about themselves. And oftentimes this is a unconscious, or not unconscious, but a subconscious process. So it might not be that female providers, and again, this isn't all female providers, but it might be that they've internalized these messages about women themselves and just think that, they're not privy to the fact that this is a bias that they may have. Mm-hmm. So now in medical schools, they do talk a lot about provider bias, whether that's gendered bias, racial bias, a lot of bias against overweight folks, and ability, right? Like making sure that people with different abilities aren't being discriminated against subconsciously. So there is more, again, conversation and dialogue about that happening in medical training now, which is great.
How are some of those disparities affecting maternal care?
Oh, majorly. So there's really large racial disparities in maternal care and maternal health outcomes. Specifically, Black women in the United States have some of the poorest health outcomes. And that, to unpack all of that could take a really long time, but it is very clear that there have been and currently still are systems of racism and oppression that are affecting Black women during their pregnancy journey. Part of that is institutionalized racism with hospitals, with the clinicians that they're seeing. It also is about where Black women are living, especially in the South. If we go back even further and think of kind of what we would think of as quote unquote non-health policies like redlining, or where traditionally Black Americans were allowed to buy land, where they were allowed to be. Those areas are often disenfranchised. They're often not characterized with a lot of economic opportunity. Hospitals aren't necessarily incentivized to go there. There's other elements of it as well. The Black community traditionally was really great at providing healthcare for their own community, but through legal racism, a lot of those traditional ways of healing were criminalized, specifically midwifery. So midwifery was illegal in the United States up until relatively recently. Alabama was the last state to decriminalize midwifery, and this was in the last 10 years, I believe, that they decriminalized midwifery. So if you're thinking about how was the Black community or other communities, indigenous communities, for example, how were they caring for themselves? They were caring for themselves through these community means that, again, were criminalized, were stolen, were erased. So there's elements of that history of oppression as well that kind of bleed into today and help us make sense of why it is that we see some of these groups of women having poor mental health, or excuse me, not mental health, poor maternal health outcomes.
Because their mortality rate is extraordinarily high.
It's much higher. Yeah, same with Native women as well.
Double? Isn't it almost?
It's for Black women. It's it's like 2.5 times higher during pregnancy. The mortality rate and infant mortality rate for Black babies is also higher, and again for Native and Indigenous babies as well. So there's a lot of really great grassroots movements happening in Black and Indigenous communities to fight against this. So there's positive rays of hope. But again, these broken systems and these systems of oppression that are all kind of working in tandem to produce these risks for certain groups of women in the United States. So you have to remember the history of the time. So the history of the time, thinking of kind of the 1700s, 1800s into the early 1900s, you had all of these different people claiming that they were healers, what we would call quote unquote quacks, right? This is where Dr. Pepper came from. You had people selling snake oil, Dr. Pepper, all of these things that purportedly had health properties. And then you also had people going to school to become a medical clinician. And so to distinguish themselves from these quote unquote quacks, this professionalization happened whereby now you have to become licensed, you have to go to an accredited school, you have to pass an exam, and that's the system that we have now. And that's all well and good, right? Like if you're going to go into surgery, you want someone that's had a lot of education and credentialing. The problem with that, though, is it really demonized all of these other ways of healing, including midwifery. Part of it, too, was, I think, the oppression of women, because midwifery was almost predominantly done by women. And if you're going to professionalize and go to school to become a doctor, women weren't allowed to do that. And so there was this push to, for men specifically, to be a professional licensed clinician. That excluded women and women's ways of healing. And what that resulted in is more women going into the hospital to give birth by these male clinicians. And if you have that system in place for a couple decades, midwifery just, kind of fell to the wayside. And then there was a resurgence in that, I'd say, in the last 30 years. But you also had laws that back that up, again, with midwifery being criminalized. And there are certain states in the country that have stricter laws on what midwives are allowed and not allowed to do. So there still isn't parity on what midwives across the nation can do. Some states, they're allowed a little more freedom than in other states. So the history of it, is pretty fascinating. And I think it is linked to oppression, unfortunately.
What are some of the benefits of midwife-led care?
Yeah, so midwife-led care, one of the best models that we see in the research is what we call a hybrid model, and this is largely a model that Europe uses, and it's where midwives are embedded in the hospital. So you, in an emergency during birth, you do want skilled surgeons to go in and be able to do C-sections and whatever else may need to happen. But those are emergency. Most births don't end up on that trajectory. And so midwives are completely capable and well trained to handle most birthing issues. And so the best model with the best outcomes is this hybrid model where you have midwives delivering most of the care. That includes prenatal care and postnatal care. So you have one midwife through the whole entire pregnancy and postnatal journey. And they go to the hospital with you. They deliver the baby. If something does happen to occur, you have an OBGYN that's there and ready. Some states in the United States have this model. Idaho, for example, has midwives have licensure to work in the hospital. Other states don't. And I should have looked this up. I'm unclear about what midwives are allowed to do in Colorado. I'm not sure if they're able to go into the hospital or not. And then on the other end of the spectrum, you have total midwifery care right at a birth center or at home, where you'd be transferred to a hospital in the case of an emergency. And the advantages of that, again, are having one provider. And in midwifery models, it's not just centered on the baby. Our care shifted to the outcomes of the baby at the expense of the mom, right? Everybody is very focused on infant mortality. We don't want babies to die, which is great. I'm all here for that, obviously.
We're still in that.
But yeah, and we're still in that place. The consequence of that, though, is that the mother was kind of forgotten. So if you look at postnatal care in the United States, it is atrocious. We don't have exactly. What is postnatal care? Yeah. So the care of the mom really suffered from that, and it's at a detriment because what we see happening, especially in hospital settings, is what we call a cascade of interventions. You go into the hospital. If your labor isn't coming along fast enough, they might give you Pitocin, and then your labor starts to get intense, and it might become, too intense. You get epidurals. So this cascade of intervention, what essentially that means is that there's more women in the United States that end up having a C-section or have more interventions compared to other nations. And that's not necessarily great for the mom in terms of recovery, in terms of long-term reproductive health. So getting away from that cascade of interventions, focusing more or equally on mother's health as well as infant health is someplace that I think we should effort to go to. Yeah. So in the midwifery care, when you're asking that question about how midwifery care is perhaps different, I feel like it is traditionally more focused on that equal care of the mother and the baby. Mm-hmm. Yeah. So better outcomes for both. And I also think that each woman's, I think it's having options, right? Because not everyone's going to feel comfortable at a birth center or at a home. Part of that could be these stereotypes about what that looks like. So having options, like I would love to have midwives embedded in the hospital so that if your community didn't have an OBGYN or you didn't want an OBGYN unless it's an emergency, that you could have midwives and you could have your doula in there with you. And
yeah, that
sounds like you just have a friend from the start that comes along with you all the way to the end.
Yeah.
And then a little bit afterwards too.
Definitely.
Sounds lovely.
Yeah.
It
does. It sounds...
I just think of like
personal.
The midwife and the doula and the doctor all like high-fiving. It's like your little birth team.
Yeah.
When I was in Grand Junction for my 2 weeks of fun, there was a birth center, right? I would go for my little daily walks and I wasn't allowed very far. So from the hospital, there was actually a birth center right next to the hospital. And now that totally makes sense that they would be close.
Yeah.
But then you don't have to be in the hospital.
Yeah, you can transfer out. And it's a homier environment. Mm-hmm. There's less people in the hospital, so maybe less risk of infection, and just the treatment is a lot different. Yeah. And birth centers, in the hospital, I think the nurse has to come check your vital every half hour. I can't remember what it is. In the birth centers, they might not have as rigid of protocol. Obviously, they still want to make sure, they want to make sure you're safe, but they're not trying to interrupt you every hour because that's their protocol, right? So, but I think it's about options, just making sure that there's access and options for women to choose whatever they feel safest and most comfortable with.
Mm-hmm. For sure.
Would be a great start because a lot of women don't even know what the options or choices are. They just hospital is it. Mm-hmm. And they know it's going to be an uncomfortable experience, which it doesn't have to be.
Yeah.
Right? Like, it's painful, but it can also be, there's ways you can mitigate that comfort. But there is a lot of really great work going on in communities around the country. And even at the policy level, There's networks when we're thinking about rural health. Pennsylvania and New Hampshire are setting up these models of care where it's essentially kind of this big network of social workers, providers, that could include doctors and midwives, doulas, any sort of care that a woman might need. And if they travel around, so if somebody is in Gunnison and needs specific care, the team would kind of travel to them so that this woman wouldn't have to travel. So there's these kind of innovative ways of providing care in rural areas. There's also really, I would say, like progressive organizations. The Black Midwifery Collection is one, and they're out of Illinois. And they're, I would say, like power disruptors are trying to disrupt whole systems. And make birthing in the Black community a lot safer. There's a lot of Grand Junction. There's the Birth Collective, the Grand Junction Birth Collective, and that's a collection of providers that are trying to improve health outcomes on the Western Slope. And I think they came here. They came to Gunnison. And so there's networks and there's work being done. So it's not all doom and gloom. And I think that like podcasts like this and just raising an awareness about this issue is a really good step in the right direction.
So one other big issue that we talked about when we had coffee was the declining birth rate. And so what role, we've talked about like the role of climate change playing into the younger generation's decisions about having children or not having children.
Yeah.
It's kind of interesting.
Yeah, everybody right now is in a tizzy about the declining the declining birth rate in the United States. But our birth rate has been declining for the last couple of decades. Really, the element that's propping it up is immigration. So if you're looking at how populations sustain or grow, they can either do that through birth or through immigration. But the native-born population in the United States, people are having less kids, and it's been pretty kind of stagnant or in decline for a long time. And that's not necessarily a bad thing, especially as it relates to climate change, because we consume more than other people around the world. And so having less kids for us probably means a better way to fight climate change. And part of the reason the decision-making behind reproductive choices is also climate change. So it's this interesting dynamic that's occurring. But yeah, there's a lot of what we would call eco-anxiety, eco-grief, just worry, stress around the state of the world. And that is factoring into people's reproductive decisions and whether they want to have kids or the number of kids that they want.
Is climate change the primary factor?
I'd say it's not definitive in the research. I would say in my own research experience with the younger generation, so we're thinking of like 18 to 29-year-olds, climate change is probably a top 5 factor. I think the biggest factor is the economy. It's just people cannot afford to live, let alone support kids. So that is the biggest factor, is the economy. And then climate change is also thrown in there.
Do you feel like that discussion is happening worldwide?
Yes.
Like the climate change affecting child birth rates?
Yeah, and I think what we see, there's a really clear pattern with declining birth rates. Japan, Italy, Germany, they've been experiencing declining birth rates for the last 2-3 decades. And really what we see is that as women's equality becomes more equal to men's and women have more opportunities, economic and educational opportunities, they are deciding that they don't want to have kids and then also come home and do all of the domestic work. And so as women's equality expands, reproduction goes down because women finally have a choice in family planning. And so that is another really big driver.
Can we, like, foundationally, why do governments care about population? And I know that seems like kind of basic, but I think it's really important.
Yeah. And especially now, again, even though our birth rate has been declining, it hasn't been a really big conversation piece in the United States to the level it has been now. And I think now it's becoming really integral because there is this really strict immigration policy in place. So if we start seeing immigration stop to the United States, we're going to see this precipitous drop in our growth, population growth rate. Governments care about it because we have a huge aging population. And if we don't have young people to take the place of people that are retiring, it will send the economy into a downward spiral. Many think that it's not conducive to our current capitalist state, and maybe that's a good thing. But a lot of people believe that scares a lot of people. So in Japan, for example, they don't have enough young people to take the jobs of the older generations that retired. They are supplementing that with technology and AI, but you can't take every job. Not technology can't take every job or do every job. So that's fundamentally why we care about it. It's not for reasons of altruism. It's because of the economy. But it's also a shame because if a woman decides to be child-free for any reason, that's great. But we do see women restricting their choice because of these financial or climate, these other kind of social pressures. A lot of women would have more kids if they were able to. Yeah. So it is confining our women's choice to some degree. It's like giving us choice to say no, but it's also restricting our choice to have more if we wanted. And that's, again, kind of this interesting paradox.
So it seems like the administration thinks, okay, if we give them more money, that'll help encourage them to have more kids.
Yeah. So you can give one-time incentive, right? Like a baby bonus is what it's often referred to. And that can definitely, who's going to turn down money after having a kid? But that doesn't create meaningful long-term change. That's not going to lift $500, which I think is what the administration was. Is either 500 or 5,000?
It was 5,000, yeah.
Which honestly probably wouldn't even cover the cost of a hospital birth. So pro-family policy, the low-hanging fruit, or probably the least effective, would be like a baby bonus. Other policies that certain countries have implemented are free childcare up to the age of 2, paternal leave, so guaranteed paternal leave for dads as well, which would be great. Those seem to be the big three. But the research is mixed in terms of, does that actually facilitate more babies being born? And we find that it's not necessarily always the case, that despite having those policies in place that help families, when people are still choosing not to have kids. So like the climate anxiety and not skepticism, but worry about climate could be one of the other elements leading to them not remaining child-free. But in this country, pro-family policy would be a huge boon. We essentially have nothing. We have some of the worst maternal leave policy. Most employers don't offer paternal leave. Childcare is an exorbitant expense, if you can even get it. There's lots of things in this country we could start to do to lay the foundation for having families be easier. It's just a matter of whether we will do that or not, whether we'll prioritize it.
And is also the division of labor at home.
Yeah, and so that's a change around gender norms and having those discussions. We do see the research is clear that millennial dads are spending more time with their kids than any other previous generation. They're also doing more housework, but women are still doing more housework than men and still providing more of the childcare. So that not that it's a burden, but that level of work is still higher for women than men, even though millennial dads are like trying to catch up. That's great. We'll see about Gen Z dads. Yeah. I'm excited for them.
Come through, Gen Z.
Yeah.
Do you think it's going to cause a shift the other way, where they're actually going to start taking away more female rights?
It feels like it
to
is.
force us into how it used to be, where we're having multiple kids and we're just staying home.
Yeah. I feel like we are living in an era that has become highly polarized. I don't know the reality of that polarization, right? Like in the media seems to be very polarized, even sometimes politically. But I do think there's a lot of people in the middle in terms of political beliefs, and they're just hanging out there kind of unheard, right? I am very curious to see what happens in the midterm elections next year, because I think there is pushback, right? There's pushback to some of these more maybe kind of like radical beliefs as it relates to women's health and women's role in society. And it's not just women pushing back, it's also men. So that's something that I find a lot of hope in, is that there are men out there on the front line having their voices heard, saying that women are important. These issues surrounding women are important. So I think we need men to realize that women's equality will also lift them up, because men are also struggling. I think that's kind of the flip side to this, is that men are struggling. We have really rigid forms of masculinity and what a male's role is in the world. And because of that, we see really poor health outcomes for men, especially mental health outcomes, higher rates of substance use for men, higher rates of suicide rates for men, more violence and injury from men. So the men are also not all right. So if we can spread this message that if a rising tide lifts all boats, right? And that if we can get men or have messages out there that women's equality is also really good for men and their ability to seek mental health and talk about their feelings and have deep, meaningful relationships that aren't violent, that's would help them as well. So I do see kind of hope in that, in messaging for men, and men being more willing to talk about women's issues and women's rights. But yeah, it's a difficult time to live in terms of the polarization of aspects. And I think policy-wise, just making our voice heard at the local level. We're fortunate to live in a state that has a lot of protections for women, especially women's health and reproductive choices. So making sure that at least our state stays strong, and having your voice heard in whatever way that feels good for you, right? Calling your representatives, protesting, whatever, donating money, right? There's different ways to be involved. We don't all have to be on the front line. But yeah, there's resistance, for sure.
Yeah, it's interesting that you say that about the men too. They're in such a fragile space right now as well, that it's almost an in for some of these toxic beliefs
100%.
to start using, like getting that message out and trying to give them something to cling to when they don't know what they want in life anymore.
Yeah, that is a great point, Megan. And we do see that happening, that more young men are, you could call it, becoming radicalized. And we see this with a lot of mass shooters, are probably the most extreme example of this. A lot of them have very extreme beliefs about women or other groups of people, like immigrants. And these are, for the most part, are like good boys, right? Like if we look at the perpetrator of the Charlie Kirk assassination, like was in a stable family environment and a middle class income, was white, like had a lot of these privileges that in society, but still has become radicalized. And so there's a missing piece with boys' mental health specifically, but also what we find in sociology and psychology is it's the relationships. Men and boys are not having the number and the depth of relationships that men had in the past. And that's from a variety of factors that are all really interesting. A lot of it stems from boyhood, and there aren't a lot of groups, organizations that boys can join anymore. The Boy Scouts disbanded because of really valid reasons related to sexual abuse. But in the 90s, you had all these resurgence, and you had male-dominated organizations like the Boy Scouts open up to girls, right? The 90s was all girl powers. I was there for it, was living it, benefited from it. It was
Spice
great.
Girls forever.
Yeah. So the opportunities for women increased exponentially, and that did not happen for boys. So what we saw is that a lot of organizations became co-ed, and what we have today is we have very few organizations that are for boys specifically. And that is problematic because we don't have space for boys to commune with each other, to build these really strong relationships, especially if they don't want to do sports. Sports is kind of the last bastion of that, but that's also traditionally, it's also very rigid norms of masculinity in sports. So if you're queer or if you don't want to do sports, right, like how are you going to feel in that sports space? It's pretty challenging. So boys have kind of, we just didn't build up the same level of involvement in organizations for boys that we did with girls in the 90s. And we're seeing the repercussions of that in addition to technology, access to technology. Yeah. So you have vulnerable boys who don't feel like they're connected to their community, to their family, to friends, and they may go into these online spaces and feel vulnerable, become radicalized, become, a victim of something. And we are definitely seeing that happen, and it is scary. And so one of the solutions to that is to creating organizations for boys specifically. And I know, as a feminist, that sometimes it's like, oh, I better say this and word this in the right way, that we need men-only spaces, because I don't want to sound like I've taken the red pill. But that is kind of what we need. We need spaces for boys. Yeah. The Mentors program here in Gunnison, they just got a big grant to do a rites of passage program for boys specifically.
Oh, that's great.
Yeah. And another element of this, too, that I find really fascinating is it's not just about having organizations for boys. You need men leading those organizations. Because if you look at volunteer rates, it's almost all women. It's moms volunteering, it's grandmothers volunteering, aunts. It's not a lot of men
women
volunteering.
Working for nonprofits.
Or you women for working in the social service nonprofit sector. You don't see a lot of male role models in those spaces. And so one of the leading sociologists, his name's Robert Putnam, and he's written extensively about this. His antidote to this problem or issue is to have male role models leading boys-only organizations, starting, really young. Right. And we just don't really have those systems in place yet. Again, I think Mentors is a good example of trying to get that going. But their wait list for male boys who want a male mentor is really long in the Valley.
There's also a men's group in the Valley.
Yeah, Brothers Helping Brothers.
Yeah, so we'll share that again, because I think that's so important.
I might just share that every time.
Every time. So what does the new norm look like in family dynamics with the birth rate going down?
Yeah, in terms of siblings. So as the birth rate goes down, family structure will inevitably change. We already made a massive change. We used to have a more extended family where you would live with multiple generations under one household. That moved into what we have now. So we're part of a nuclear family. But as people decide to have no children or fewer children, we're seeing interesting changes in sibling dynamics, because not only are people choosing to have less kids, they're choosing to space their kids out longer. So you have larger age gaps between siblings, and that likely is going to change sibling dynamics and just family dynamics in general. So we're not quite sure what that will look like, but people also have less cousins because they're having fewer kids. So we don't know what the new norm will look like, but the norm, I would say, is changing. And because it's expensive to live, we might go back to that intergenerational model or cohabitation model, communal living model.
I like that model.
Yeah, it could be good. It could be really great. And so to be determined, but there will be changes for sure.
And in the 90s, the typical family size was 3 kids.
I'd say 2.5, 3.
I don't know how that works.
Before that, it was 4.5, 5.
Oh.
And now it's 2. It's actually 2.2 is quote unquote replacement level in demographic speak, and we're under that, so it's slightly less than 2 kids per family
1.8 or something.
Yeah, but so it's about 2 is the norm, but it's very common for people to just have 1 kid now.
I think I know so many people that just have 1 and they are only having 1.
Yeah, so just think about that in terms of how different that's been from the rest of human history. To most humans throughout history have had siblings, and probably a lot of siblings. Some of those siblings likely have died or in infancy. To now only just being an only child. So again, we don't know what that will mean for family dynamics, but it's going to be an interesting change, I think. Yeah.
I know Avery will often say, well, that friend of mine has a sister or has a brother, but then it's different. It's weird because most of her friends don't have that. So she'll
like, "My
even
one
bring
friend
it
has a
up. She'll be
brother."
like, yeah, he has a brother. Like, well, that's cool. Like, yeah, it's so
It's like
funny.
a descriptor now. Like, he's got a brother.
Yeah, like, it's kind of funny.
That's funny. Yeah. Well, it's super, super relevant to our situation right now. I mean, like mine at least. I know I've had some conversations with both of you about like feeling really strongly one way or another and shifting back and forth between like, yeah, I definitely want another kid, or no, I absolutely don't. And like, if I did, I would have to wait till she's at this age so I don't have to pay for childcare.
You can afford it. Yeah, that's spacing.
the number one.
Yeah.
Relevant to a decision to have another kid, like for me, was childcare costs. And so like, that's why I would space out. So when we talk about spacing them out, there's different factors that might be causing someone to make that decision. For me, it would be, well, I don't have to pay for childcare anymore.
Yeah, and that's a huge one. That's probably the number one. And age. I mean, women are having kids later. In age, and so that's also a factor in how many kids people have and then the spacing of it. Mm-hmm. If you're older, you might have to have rapid succession in kids, but if you're younger, you can maybe space it out and have those considerations play into it more.
Yeah.
I know that climate change was definitely a factor for me. Then endometriosis decided what it was going to be. But it was definitely, heavily being factored in and causing me to hesitate and having a second. I always thought I would have a second. But then you have the first.
It changes everything when you have the first.
It does. How you see the world.
Yeah.
You just never, I think you go into it and you think, this is what I really want my family life to be. And I want 2 kids or 3 kids or however many.
And then you have the first.
And then you have the first and you're like, maybe I don't.
Yeah. And then you realize
Not
how
that
hard
it's
it is.
hard, but it's.
Well, there's just a lack of
it's-
support too. Like if there are things our society could do to make it easier for us, and that it's a shame that we don't do that, and it's frustrating, and especially if it like limits or confines your choice. That's where I get frustrated and
exactly
kind of upset about it. It's like, oh, people could be having more kids, but if they wanted, but
Yeah, I mean, just giving you the one-time, baby bonus isn't a solution for long-term birth rates.
No, that's not even going to make a dent.
Yeah.
So according from like research from Japan and like South Korea, who
better
tried to do
economy,
that.
so increased pay.
Yeah, I think
Gender.
family friendly policies, changes to the healthcare system, right? Why there's nothing that says that women have to pay for childcare, but we make them pay through our healthcare system. So having it be free to have a kid, having different avenues of care, either birth centers, midwifery, the hybrid model, whatever it may be, gender equity, gender parity in domestic work, changes in family, having intergenerational families rather than nuclear families. So yeah, there's lots of different things that can change that would help young families. And we're essentially doing nothing. Yeah, you need those systematic and cultural changes before we see any big trend change in birth rates in the United States.
Do you think that's associated with health outcomes as well? Like, there's a correlation?
Yeah,
I don't know if it's
I think so.
causation.
Yeah, I think it's definitely interwoven because we do find better mental health outcomes for both parents if they have longer leave. So if they have better maternal and paternal leave that is paid for, that's not causing a financial stress. That's the best for the whole family. Even if they have other older kids, that's good for the older kids. It's good for the infant. It boosts breastfeeding rates quite a bit. The number one reason why women don't breastfeed is because they have to work. So yes, they're all connected.
So looking ahead, what's next for your research?
I'm not quite sure. I've gotten really into menopause.
Yes, please.
Because I think, one, it is understudied, it's under-researched. It's also just personally, like, that is my next phase of life.
Right.
Like, I've done kids. And so I think I would really like to delve into studying menopause and maybe in rural areas and link it to access of care and equity. So yeah, that's where I'd like to go.
And your work is published, so where can people access
Yeah,
research?
they're largely in academic journals that are paywalled, but you could Google Scholar, my name, and you'll see some articles. I'll have a recent article coming out with a couple of colleagues on the effects of air pollution and health behavior and reproductive decisions, in the way that air pollution factors into that for women living in places with a lot of air pollution.
And we can link it. There's a paywall, but we can link it.
Yeah, sure.
Okay.
Do you have like a moment that you can think of where you're like, we could still do this. The village is still here.
I think one of a great example of the village coming together, and this is a really simplistic example, but I think it's very meaningful, are meal trains for women after they have a kid, or if they have an other injury or something like that. But usually it's after a kid. And I think that's a really beautiful, simplistic way to show that the village is there. Something as simple as bringing a meal so that the woman or father, the parents, don't have to cook. And I really like that. It's almost a form of mutual aid, really. And I think it's really beautiful. And it's a very old historic tradition to do that for your community, and welcoming a new baby. So I like that example a lot.
I love it.
Top most mentioned topic on our podcast is meal trains.
Yeah.
Really?
I feel like almost every
mentioned
Other
all
people?
the time, yeah.
Whoa. I wonder if it's because that's also
so
like
tangible.
one of the, it's tangible.
It is.
And it's one of the most common forms of mutual aid that we have is meal trains.
And you're like-
that's really interesting. Also, I think it's like so helpful just to have food, not have to stress about food.
It's so much mental load.
Yeah.
We had Avery. We had a neighbor drop off. They just put it by our door, like slipped it into the door as a little gift card to, I don't know, one of
Like
the
a restaurant.
restaurants. I think it was Pisons. Because she works with a friend of ours, and our friend had told her that we had a baby, and so she brought one over with a nice note.
Yeah.
We'd never met her before.
That's
She
so
just did
sweet,
that
right?
Because she knew we would need support.
It's an act of
It's very
generosity
sweet.
that's like meaningful and accessible to people. I wish we had other forms of like mutual aid that we just kind of readily did, but it's not really built into our society. So I feel like meal trains are it's like the one.
It's the one that works, yeah.
There are good models of people pooling money together and then having just mutual aid that way, like financial assistance. And it doesn't have to be big things. It could be small things like new shoes for school or whatever.
Right.
So I don't know if we have that in the community. I feel like the Gunnison Valley Humanity Posse would probably be the best source of that. I don't know where that funding would live, how you'd access it, but that's also really common in other communities for a form of mutual aid, housing assistance, things of that nature.
Okay. Yay. Well, thank you so much.
Yeah, that was incredible.
My pleasure.
Yeah, thank you.
I want to talk to you for 7 more hours. But I'll just have to audit one of your classes instead.
Yes.
Well, yeah, thank you so much for being here. Once again, Jessica Eckhardt. Can you spell your last name for us, just in case?
ECKHARDT.
Okay, awesome. Well, thank you for being on It Takes a Village. Don't forget to follow us on Instagram at ITA_village_pod. Email us with any questions at itavillagepodcast@gmail.com. And you don't have to be perfect. You just have to be you. We'll see you next time. Thank you.
Yay!
Thanks, ladies. That was fun.
Yeah, that was great.